Welcome back, Titans, to another episode of BMS Lecture Series. Today we are going over the Glasgow Coma Score, an important scoring system that you're going to use for every patient pre-hospital, even if they are unresponsive, which they would get a 3. A perfect score is going to be a 15, and we're going to go over that. Now, during your XABCD assessment and your primary survey, during D for disability, you're supposed to check for AVPU and their GCS. We don't check GCS just one time on our patient during initial assessment. We're going to track their GCS throughout the call. A lower GCS throughout the call can indicate neurological deficits, or a lower GCS improving throughout the call can be an overall improvement in patient condition. So, the GCS is the most commonly used and reliable, consistent method of assessing mental status and neurological function. It may take a little bit longer than AVPU, but it needs to be done on every single patient. So, GCS is broken up into 3 categories from a scale of 3 to 15 based on where you rank each assessment dynamic. We have the eyes, verbal, and motor. Starting with the highest number you can get possible for the eyes, we have spontaneous. When you walk into a room, when you walk into a scene, is the eyes of my patient spontaneous to me? Are they tracking you and your partner, or you and your crew? Are they alert enough with their eyes to be able to track? That would be a perfect 4. If we go to a 3, maybe our patient's not paying attention, they're a little lethargic. Are they responsive to verbal commands? And then they start tracking you, that'd be a 3. To pain would be a 2. And then obviously no response is going to be a 1. Once we've assessed the eyes, we can go on to verbal. Is my patient oriented? Are they alert to person, place, time, and event? Are they aware of everything that's going on? They can answer questions appropriately. That's going to be my 5. Are they disoriented? Does my patient are they not able to answer person, place, time, or event correctly? Do they seem slightly confused on the answers that they're giving? Do they maybe look into their history? Do they have maybe a dementia history and this is their normal mentation? These are the times when we're going to ask a bystander or a healthcare worker or a family member, what is their normal mentation? Your patient may be a GCS 14 all the time, and that's their baseline. Number 3, are they displaying nonsensical speech? 2, unintelligible or mumbling. They're not making any sense, but you also can't make out what the patient is saying consistently. That'd be a 2. And then obviously no verbal response is going to be a 1. After we've assessed the eyes and the verbal, we're going to go on to motor. Is my patient able to follow commands? There are a lot of treatment modalities and tools you're going to use, such as CPAP for an example, where you have to understand that your patient needs to be able to follow commands to utilize that resource. Can my patient follow commands? Can you ask your patient to raise their right hand or grip both of your hands at the same time? If they are able to follow commands, motor function, we're going to assign them a 6. Do they localize pain? Maybe they can't follow commands, but maybe they can tell you, can you feel which finger I'm grabbing? Do you understand which toe I'm grabbing? That's localizing pain. Do they withdraw from pain? Maybe they're not paying attention to you, but you do a Babinski reflex or something and they can withdraw from the pain even if they're unconscious. That'd be a 4. Now, abnormal flexion and extension, this is coming into to quarter-kit and decerebrate posturing, and I'll put a picture up on the screen. Do they have some sort of abnormal flexion in their motor response? That's going to be to quarter-kit posturing towards the core. Or do they have abnormal extension? That's where your hands are going out, and that's decerebrate posturing. Or the last one we could have is no response. We're trying all these items and all these assessment modalities, and they have no response. Now, getting to the scores, when you're identifying the GCS of your patient, we have to understand that a score of a 15 is typically no neurologic disabilities. That patient has scored perfectly in all of our GCS categories with the eyes, verbal, and motor, and we're pretty good. Is a 13 to a 14, maybe we have a mild dysfunction. A 9 to 12 is a mild to severe dysfunction. And an 8 or less, we have severe dysfunction. everybody will have a minimum of a GCS of 3, even your patients that are in cardiac arrest, because no response to each of these items, the lowest score you can have is a 3. Now, when you're documenting this on your patient care report, I would also encourage you not to just identify the GCS and say, okay, my patient was a GCS of 13, but you should also identify what made that. If it was an for eyes and it was a 3, you can put E3, verbal V4, and then motor M6. That's going to help you and also the healthcare providers in the emergency room that you're delivering your patient to identify where on the GCS they were and how they're improving, whether it be eyes, verbal, motor, or overall improvement. Hope this helps. Study your GCS. You're going to use it all the time. See you next time.